Ouch. That must have hurt. Johnny just went flying off the monkey bars, and now he has a painful, swollen arm to show for it. Here he is now in your ED, sad and sullen. Okay, position of comfort, analgesia, x-ray, and now there's reading the x-rays. What am I seeing here? Or more importantly, what am I missing here? Pediatric elbow injuries, x-ray interpretation, and some sound advice.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Caring for the child with an elbow injury has its pitfalls. Is it bruised or broken? Then there are the x-rays. Where did all the bones go? Is that a fracture fragment or an ossification center? How can I be sure I'm not missing something? And if I find it, well, what then? Elbow injuries account for 1/4 of all sports-related injuries. In children and adolescents, varying skeletal maturity throws a curveball into our normal approach. We need a solid foundation on the anatomy and how it changes with age. We'll also talk about specific patterns of injury and what to do about them. Today, let's stretch the frontiers of audio and venture to use the theater of the mind to envision and distinguish normal development from injury. Okay, here's the secret. It's a numbers game. We just have to look at a bunch of films to get a good feel for it. To get there, we need a solid approach. We need CRITOE. Remember this? CRITOE. It's the mnemonic to remember the order of ossification of the pediatric elbow. Why CRITOE? I can't tell you, but I can tell you it works. The idea behind it is this. We're all born with primary ossification centers. These are the building blocks of our bones. As we bear weight or purposefully use parts of our bodies, the traction and stress forces stimulate development of our secondary ossification centers, all the bips and bops on the ends of our long bones. It's hard enough to keep track of them all, and it can quickly get confusing when the child's injured. Is that little bip or a bop a broken bone or just a bone in the making? The good news is that we all follow a programmed development. Ossification centers thankfully follow a strict order. This is where CRITOE comes in. The capitellum is the first to develop, then the radial head, then the internal epicondyle, aka the medial epicondyle, then the trochlea, the Olecranon, and finally the external epicondyle, aka the lateral epicondyle. CRITOE, CRITOE. If you see a child who has a little bip or a bop on the Olecranon, but his radial head is not formed yet, that is totally out of order. You can't have a normal Olecranon ossification center if you don't even have a radial head yet. You're just too young for that Olecranon. The radial head, the R in CRITOE, is only the second one to be formed, and the Olecranon is second to last. In general, you can count out what age to expect for each ossification center. Now, there's wide variation in the actual age it happens, and girls, of course, mature more quickly, but an easy rule of thumb is to count by odd numbers to know when to expect the components of CRITOE to appear. So, CRITOE at 1, 3, 5, 7, 9, and 11. The capitellum appears at age 1, the radial head by age 3, the internal epicondyle by 5, trochlea by 7, Olecranon by 9, and the external epicondyle by 11. The actual numbers are not as important as knowing the programmed order of development. Okay, now let's use our mind's eye to paint a vivid picture of each stage. First, a brief anatomy review. Let's be honest, we can all use that from time to time. Imagine the elbow on an x-ray. Let's focus on the posterior anterior view. The bone at the top was called ulmus by the Greeks, which became humerus, to the Latins, from which French gets the word ombre, and Spanish hombro, shoulder. Shooting down from the humerus, like beams of bony sunshine, are the radius laterally, which comes from the same word as ray, also meaning staff or rod because of its straight course, and medially the ulna, from the Greek olene, meaning elbow. Add the Greek ending kranos, meaning head, and you get Olecranon, top of the elbow, or the most prominent bony protuberance, and what hurts the most when you whack it against the door. Why this focus on etymology? Well, the ancients were very descriptive in their nomenclature. Knowing the meanings behind the words can help us to take advantage of their descriptive nature to make them stick. If this isn't your routine, bear with me, you may find it helpful later. The top of Greek and Roman columns were always adorned with a capital, coming from the word for head. The capitellum is a small, smooth end to the humerus where it articulates with the radial head. On the medial side of the humerus is the trochlea. Trochlea, coming from the Greek word for pulley, and you can just imagine the fulcrum it represents with the ulna in elbow flexion. The trochlea meets the ulna at the coronoid, from the Greek korone, or crown, and it does look just like that. Can you see the two concave sides sloping up to the middle to make a point? It looked like a crown to the ancients. Think of the trochlea of the humerus pulling down as it bows down to the kingly coronoid crown of the ulna. All right, back to our friend CRITOE. Capitellum. By age 1, the capitellum ossifies. On the AP view, imagine a little white oval balloon floating in the darkness between the radius and the humerus. It's smooth, it's oval. If the radius were the floor and the humerus were the ceiling, the capitellum is a white, bony balloon floating just below the humerus ceiling. The capitellum says, "Hey, I'm one now." Radial head. By age 3, the capitellum gets another little balloon to join the party. The radial head is a bony little balloon that floats just above the floor, just above the radius. If you see both little balloons floating on either ends of the space between the humerus and the radius, you know this child is about 3 years old. Now, here comes the fun part. Because we know that there's a very specific order to things, we can tell already if something's missing. For example, seeing a capitellum just below the humerus in a 1-year-old is totally normal. Seeing a capitellum and a radial head in a 3-year-old is totally normal. But if, say, a 5-year-old only has a radial head, well, where's the capitellum? It's avulsed and hiding somewhere else. Internal epicondyle. By the age of 5, the capitellum and radial head are no longer little floating balloons, but now taking on shapes that resemble what they'll look like as an adult. By age 5, you've grown out of balloons and you've moved on to frisbees. The internal epicondyle starts to ossify by age 5, a bony little frisbee. Trochlea. By age 7, another little frisbee flies around. On the AP view, the trochlea is superimposed on the humerus. If you look at the distal medial humerus, you'll see the trochlea like a little oval frisbee taking shape. Again, order matters. If you saw a 7-year-old, you'd expect, let's see, CRITOE, C at 1, R at 3, 1 at 5, T at 7, so he should have a trochlea. If you have a 7-year-old after a fall and on his x-ray you see his capitellum radial head, no internal epicondyle, but somehow he has a little frisbee of a trochlea, watch out. The internal epicondyle is there. It has to be there because the trochlea is there. Look for that avulsed internal epicondyle. That elbow is fractured, my friend. Olecranon. By age 9, the olecranon of the ulna is ossifying. Remember, the olecranon has to follow the rules and take its turn. No cutting in line. In a 9-year-old, you'll see a capitellum, radial head, internal epicondyle, trochlea, and olecranon. If you had, say, a 5-year-old who looks like he's starting on an olecranon, hold on there. Let's take inventory of his 5-year-old elbow. He got a capitellum at 1, radial head at 3, internal epicondyle at 5, and that's it. If you think you see an olecranon, then where's the trochlea? He can't skip his trochlea and go straight for an olecranon. Not only is he too young for it, but more importantly, he's out of order. That's not an olecranon. That's a fracture fragment. You can also look here for other indirect signs of fracture to help put this irregularity in context. Again, even if this 5-year-old were mature for his age, look to see what's missing here. Okay, here we go. Repetition is the mother of memory. It goes capitellum, radial head, internal epicondyle, trochlea, then olecranon. No trochlea? And you want to call that an olecranon? We've got a problem. External epicondyle. By age 11, many of the early ossification centers are looking more like their adult counterparts. These films are getting easier to read. Now, that's not to say that the ossification centers are fused. Fusion comes later in mid to late adolescence. I mean that the ossification centers by age 11 look more like themselves than bony little balloons or floating frisbees. By 11, you start to ossify your external epicondyle, meaning your lateral epicondyle. Even if you have all of your other ossification centers accounted for, be careful when looking at this last lateral frisbee. Like the others, it should be smooth and closely associated with the humerus. If it appears to be widened or irregular, it may be avulsed. Oof, that was a lot. Our imagination just got a workout. The good news is that even if you're not still very comfortable with the ossification centers, by the way, work on them, it will get easier, you can still catch indirect findings that point to a fracture. These 3 things can save us: fat pads, the anterior humeral line, and the radiocapitellar line. Okay, fat pads. Now we're looking at the lateral view. An adequate lateral view shows the humerus perpendicular and the radius and ulna at 90 degrees horizontal. Make sure to insist on adequate films. Now, it's perfectly fine to have some hypodensity in the space anterior to the humerus. Everyone has some fat there. What is abnormal is the sail sign. When blood fills the antecubital space, the fat pad billows out and looks like a sail in the wind of a bloody storm. Make sure the penetration's right, and if you're reading the films on an electronic screen, make sure that the monitor has high enough resolution to see what could be a subtle bulging line bowing away from the humerus, signaling an occult fracture. You may see disruption of the hourglass shape of the humerus. The olecranon fossa of the distal humerus is the narrowest part of the humerus. It's also the most mechanically vulnerable, which makes it a prime location for a fracture in children. On the lateral view, the coved-out fossa takes on a shape reminiscent of an hourglass, or some will call it a figure 8. Look for that shape. It should be smooth and symmetric. If you see what could be a fuller than usual anterior fat pad and your hourglass is broken, well, those aren't the sands of time leaking out into the anterior arm. It's blood from a fracture. Now, here's the easier one. A posterior fat pad is always pathologic. Now, I'm not talking about the thin linear lucency that we all have surrounding our humerus posteriorly. Look, and if you see any non-uniform outpouching of darkness around the back of the bright bone of the humerus, that's a fracture. Fat pads can save us when our eyes don't see an obvious bony abnormality. The anterior humeral line. Here's where it gets real. On the lateral view, think of the distal humerus like a hockey stick. Can you see it? It angles just slightly towards the forearm. We can take advantage of this natural angle to verify the bony relationships. If you draw a line along the anterior humerus on the lateral view, it should intersect the middle 1/3 of the capitellum. Remember, the capitellum is the lateral portion of the distal humerus. It should be angled up away from the humerus slightly. A nice, happy humerus has a humeral line that merrily meets the capitellum in its middle third. A subtle fracture may be only seen by following the anterior humeral line down, only to find that that line either misses the capitellum entirely or only barely intersects it. The radiocapitellar line. The last of the trio that can save us from missing a fracture. Like the distal humerus, the radial neck is not totally in line with the radial shaft. The radial neck is in line with the radial head. The two form a straight line, but the radial neck is angulated slightly from the rest of the radius. This is important to remember. Draw a line along the middle of the radial neck and through the radial head. It should bisect the capitellum. If it doesn't, there's a fracture dislocation. Be careful not to use the entire radial shaft for this line. It can lead you astray. Draw the line through the middle of the radial neck and through the radial head. If it bisects the capitellum, that's normal. Otherwise, assume a bony injury. One bonus line. Yes, I know I mentioned only 3 things. The fat pads, the anterior humeral line, and the radiocapitellar line. But if you really want to take this to the next level, I have one more thing for you. Bauman's angle. If you put your arms and forearms in anatomic position, so with your arms out to your sides and your palms facing out, go ahead now, try it if you're not driving. In anatomic position, we all have some angulation laterally. This is your carrying angle, a normal functional feature that allows us to, carry things. Think how hard it would be to carry a mastodon bone, or later a bucket of water, or now a grocery bag without some lateral angulation. Its physiologic function imprinted in anatomic efficiency. Bauman's angle is an objective way to measure your normal carrying angle. Think back to the AP view now, and in your mind, draw a line down the middle of the humeral shaft, and another line along the lateral condylar physis. So basically, one vertical line up and down the humerus, and one horizontal line riding along the edge of the capitellum. A normal angle is 70 to 75 degrees. You may have to take another film of the other side to compare, and a difference between extremities of just 5 degrees or more is abnormal. We need to catch this because too much valgus deviation can be harmful. So, deviation that results in the forearm jutting away from the body in anatomic position. Valgus deviation will lead to functional impairment. Bauman's line may be helpful in diagnosis of a fracture dislocation, but more importantly, it's used to decide whether your reduction was adequate. Supracondylar fractures are the most common elbow fractures in children, making up to 80% of pediatric elbow fractures. Most of the time, this is a fall on an outstretched hand, and the child comes in with a swollen or at least painful elbow, and he does not want to move it. Evaluate for other head, neck, torso, abdominal injuries, or other ortho injuries, but oftentimes it's just the elbow. We use the Gartland classification to categorize supracondylar fractures. It's been modified several times over the years with subtle differences, but we'll just focus on what we need to know in the ED. There are 3 major types. Speaking broadly, type 1 fractures are minimally displaced and need only a cast. Type 3 fractures all need surgery, and type 2 fractures fall somewhere in the middle. A Gartland type 1 supracondylar fracture is minimally displaced. These are subtle transverse fractures that are stable with generalized swelling around the elbow without nerve or vascular compromise. You may just see a sale sign in the anterior fat pad. After we cast a child with a type 1 fracture, he can go home with good precautions. We immobilize type 1 fractures with a cast for 3 to 4 weeks, and in clinic, they may refilm in 1 week to recheck alignment. Type 2 fractures are angulated. The anterior cortex is displaced, but there's still an intact posterior cortex. Nearly all of these children will stay overnight for 2 reasons. 1, we're always on the lookout for compartment syndrome here. And 2, even after closed reduction, the child may need more aggressive intervention. These type 2 fractures can be tricky because they'll all need closed reduction, but only some will need percutaneous fixation. This has led to a modification into subtypes, depending on how well the closed reduction in the ED went. Basically, it just has to do with whether or not there's a rotational displacement. We won't get into the weeds here, but various studies have shown poor agreement among pediatric orthopedists as to the subtypes, so let's just be aware of the variability in identification and management. Type 2A injuries have no rotational component and can be treated with closed reduction and casting or percutaneous pinning. Type 2B injuries have some rotational component and should have closed reduction and percutaneous pinning to prevent coronal and or rotational malalignment. Rotation is very difficult to discern on plain films, so it may be that just using the C-arm we can figure this out. The bottom line for type 2 supracondylar fractures is that A, we often admit for serial exams, and B, there's going to be a judgment call by the orthopedist as to surgical pinning or not. Type 3 supracondylar fractures are more straightforward. That elbow is torn up. They are totally displaced with no cortical contact. They should be closed reduced initially, then they will all need surgery. These fractures put the child at highest risk for compartment syndrome, which can start subtly, but can have lasting consequences. The anterior compartment of the arm houses the muscles of flexion, so the biceps brachii, the brachialis, and the coracobrachialis, innervated by the musculocutaneous nerve and supplied by the brachial artery. The posterior compartment of the arm is the extensor compartment. This houses the triceps and the anconeus muscle, and it's innervated by the radial nerve and supplied by the profunda brachii. Supracondylar fractures are typically anteriorly displaced and so affect the anterior compartment of the arm. If the anterior compartment experiences increasing pressure from blood or edema, the brachial artery, just above the elbow, is gradually occluded, causing acute ischemia, then necrosis of the flexor muscles of the forearm, most notably the flexor digitorum profundus and the flexor pollicis longus. Basically, it's like an internal tourniquet just above the elbow that turns these guys into beef jerky. Days to weeks later, now that they're fibrotic and short, you end up with a permanent flexion contracture of the wrist, a claw hand. This is called Volkmann's ischemic contracture, and we need to avoid this at all costs, or the child's function will forever be compromised, or his forearm later may be so dysfunctional or insensate that he's at risk for gangrene and may need an amputation. Thankfully, this is rare. When we typically think of the 6 Ps of compartment syndrome, you remember pain out of proportion to exam, paresthesias, pallor, poikilothermia, pulselessness, and paralysis. These are all great for textbooks and for adults, but we have to be careful here. The 6 Ps of compartment syndrome just aren't sensitive enough in children. Really, the one and only thing that may tip you off to increasing compartment pressures in children is an increasing need for analgesics. This and a restlessness and inconsolability may be the only things that point us to a brewing compartment syndrome. Remember, the bulk of pain control happens in reduction and casting. Anatomic realignment and maybe some mild analgesia are all that's needed. If you're giving your pediatric patient increasing doses of opioids after reduction of a supracondylar fracture, this is not normal, and you need to sound the alarm that compartment syndrome is getting likelier by the minute. Children with type 3 supracondylar fractures are admitted for urgent surgery with frequent neurovascular assessments for compartment syndrome. There does exist a type 4 supracondylar fracture. It's totally displaced without any periosteal support. But this diagnosis is only made in the OR, so I mention it for us to be aware of, but for our good orthopedic colleagues to sort out. Okay, that is the bulk of what we need to know about elbow injuries in children. If we can master the supracondylar fracture, then we have our highest yield info under our belts. But I appreciate that you want to know just a bit more. To make this as fun and easy as possible, let's do this rapid fire. Here we go. Less common elbow injuries. A lateral condyle fracture is also caused by a fall on an outstretched hand and is the next most common elbow fracture in children. They'll have focal tenderness, soft tissue swelling, or ecchymosis over the lateral epicondyle. There may only be a sail sign or posterior fat pad on an x-ray here, so a lateral condyle fracture can be mistaken for a subtle type 1 supracondylar fracture. If not displaced, a long arm cast will do them well. If the lateral condyle fracture is displaced more than 2 millimeters, many will need open reduction and pinning with Kirschner wires. You know, those skinny percutaneous pins. These guys are at risk for malunion, so close follow-up is important, especially if no surgery is planned. Medial epicondyle fractures are similar in mechanism, but many of these, up to 50%, are associated with an elbow dislocation. Be careful with elbow dislocation in children. We may not appreciate the medial epicondyle fracture that goes along with it. Up to 15% of the time, the medial epicondyle gets entrapped in the joint when we relocate the elbow. If the medial epicondyle fracture is minimally displaced, so with these guys less than 5 millimeters, then it can be immobilized with a posterior splint for a week. Then range of motion exercises can be started to avoid a stiff elbow. Interestingly, a recent long-term outcome study of even moderately displaced fractures of the medial epicondyle showed no difference in surgical versus conservative management. Follow-up is important here as well. Radial head and radial neck fractures are less common in children. These happen, you guessed it, with a foosh. Treatment depends on the amount of angulation between the head of the radius and the radial shaft. Up to 50 degrees angulation may be treated without surgery. Closed reduction mostly does the trick, but if unsuccessful or very angulated, the child may need OR time. Radial head fractures are at risk for avascular necrosis and non-union. Olecranon fractures are also uncommon and happen in older school-age children, typically between 7 to 11 years of age. Most are very minimally displaced, and they rarely require surgery. A long-armed cast for 4 to 6 weeks is usually the treatment. Complications include ulnar or radial nerve palsies, but interestingly also, these often do amazingly well and self-resolve once the edema improves. Now, a few non-fracture injuries around the elbow in children. Elbow dislocation is relatively rare in children, but unlike in adults, it can be associated with a fracture. We mentioned the medial epicondyle fracture, but think about the radial neck as well. Perform procedural sedation and prompt reduction by following the opposite trajectory of injury. Once the coronoid process of the ulna clears the trochlea of the humerus, you'll feel that welcome clunk. Take the elbow through its range of motion after relocation. Film the joint to verify that the medial epicondyle and radial head are accounted for and uninjured. Do a good motor, sensory, vascular exam, both pre and post reduction. Immobilize with a posterior splint for a week, then range of motion exercises and good follow-up. Radial head subluxation is the fancy term for nursemaid's elbow. Typically, this is from a sudden jerking of the arm, or if the child is swung by his arms. Usually, this is a toddler's injury. Most cases present between 1 to 3 years of age, but infants as young as 4 to 6 months may present this way. Just make sure the mechanism makes sense. The oldest child here may be 7 or 8, but this is getting pretty rare because the annular ligament covering the radial head and what keeps it in place strengthens rapidly after age 3. The young child will come in perhaps just not using his arm or not wanting to move his elbow. There shouldn't be any appreciable swelling or point tenderness. If so, think supracondylar fracture or get an x-ray before you attempt reduction. Now, we've all been there before. So keen on reducing a nursemaid's elbow that we crank on a poor kid's supracondylar fracture. Film first for the swollen elbow, or if it's not straightforward. Anyway, the child with the nursemaids is more anxious than he is in pain. Explain calmly and assuredly to mom or dad what this is, and that with a simple maneuver, you'll likely be able to fix it. The child will cry for a moment, but none of this is pleasant, right? Ideally, you give an NSAID first, let that take some effect, which also gives you enough time to track down a trainee or a nurse who's never done one of these before and get back in there and make him or her the superhero. Because with a few simple maneuvers, you can fix them right away. How many things in medicine can we say that about? 2 techniques can be used. Technique number 1 is the supination flexion technique. Face the child and hold your thumb firmly but gently over the radial head. Put the forearm in full supination, so the palm is facing the ceiling. Apply gentle traction to the upper extremity while you fully flex the arm. You may feel a little click of the radial head back into the annular ligament. The second technique is the hyperpronation technique. You can either hold the elbow at 90 degrees or fully extended. Again, with your thumb firmly but gently over the radial head, you hyperpronate the forearm, turning the palm towards the ground. In an often quoted study by Macias et al. In Pediatrics, 90 subjects were randomized to hyperpronation versus supination as the first attempt method. 2 patients in the hyperpronation group required 2 attempts versus 10 patients in the supination group. Hyperpronation was found to be more successful with 40 of the 41 patients, so 97.5% in the hyperpronation group were reduced successfully versus 38 of the 44 patients, so 86% in the supination group. The authors conclude that the hyperpronation technique required fewer attempts at reduction compared with supination. Hyperpronation was successful more often than supination and was often successful even when supination failed. Hyperpronation is often the less painful approach as well. In practice, honestly, I often start with hyperpronation and follow through with supination, all in one coordinated effort. For me, it's one and done. You can leave Johnny to relax after your maneuver, and 20 minutes later, he's miraculously using his arm. If Johnny were still hesitant, try offering him something from his affected side to get him to use that arm. The only aftercare intervention is a little supportive counseling about how to avoid this in the future. Medial epicondylar apophysitis is also called little leaguer's elbow. It's a chronic overuse injury of the medial humeral condyle caused by a repetitive valgus stress, resulting in osseous damage of the elbow. This injury can be seen in baseball players, or in tennis, or in high-lie, or even in football players. Any sport that involves repetitive throwing, especially with the dominant hand. Plain radiographs may show hypertrophy or separation of the medial humeral condyle. Treatment consists of rest until symptoms are completely resolved, followed by a retraining in proper throwing mechanics. Little leaguer's elbow is the pediatric equivalent to adult conditions like medial epicondylitis or golfer's elbow, or lateral epicondylitis or tennis elbow. Both are mostly treated with rest, NSAIDs, and possibly a sports brace. In summary, the most important pediatric elbow injury is the supracondylar fracture. Grade 1 is minimally displaced and needs a cast. Grade 2 is displaced but with the posterior cortex intact. After closed reduction, the child may still need surgery. Grade 3 fractures all need closed reduction, internal fixation, and close monitoring for compartment syndrome. CRITOE gives us the order of ossification for the pediatric elbow. Capitellum, radial head, internal epicondyle, trochlea, olecranon, external epicondyle. Typically occurring at years 1, 3, 5, 7, 9, and 11. Remember, the order is the most important thing here. All ossification centers should be accounted for. Make sure one is not missing or that a fake-out hasn't been created traumatically. Other things to save you when looking for subtle fractures include the anterior humeral line. On the lateral view, a line drawn down the anterior humerus, if it intersects with the middle third of the capitellum, that's normal. If not, suspect a supracondylar fracture. The radiocapitellar line runs along the radial neck through the radial head and should line up nicely with the capitellum. If not, assume a fracture dislocation. And lastly, close communication and coordination with the orthopedist will help us to offer the right care at the right time. There is some variability with orthopedic practice, so be open to that. We can make our biggest impact by making the right diagnosis, aggressively treating pain, and effectively providing procedural sedation when needed. Thank you very much for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.